the FHIR resources that are available in the clinical quality, the clinical reasoning module within FHIR. So, so first, what's a quality measure? We'll start there. Hopefully you're somewhat familiar with those, but we'll just start. Quantitative tool to assess the performance of an individual organization related to a specific process or outcome. So these are measures that payers or agencies will use to try to assess whether or not quality care is being delivered according to guidelines and ideally the best evidence available. So an e-measure then is a digital computable representation of that quality measure. They're typically evaluated at a population level, but we can also get down into evaluate at the individual patient level. So measure types. Process measures is something that measures focused on some actual process or workflow. So a measure that evaluates cancer screening rates, for example. Or something that makes sure that you're doing some process. Ideally, again, there's evidence behind that makes sure that process is something that actually improves outcome. But there's a difference between the next kind, the outcome measure, that actually measures a particular outcome. So something that says, did their blood pressure improve? Did their actual asthma control improve over time? That's an outcome measure versus a process measure that would say, did you give them the asthma screening or the asthma control test? Structure measure is something that then focuses on a healthcare provider's capacity, number of beds, nurse to staff ratio, those types of things. And then we have two kind of outliers there. Patient-reported outcome, which is an outcome that focuses on patient engagement. So something that it's been found that a lot of, if you just ask the patients, I know it sounds kind of simple, but if you ask them, kind of more general questions like how are you feeling or patient experience, that those often correlate very well with their actual improvement in clinical outcome. So I don't know if you've heard of things like the promise measures. Those are measures that are based on and studies around actually just engaging the patients as much as possible in measuring the outcomes. So those are an important part, and then we have a specific category for those. And then a composite measure is one that is made up of multiple measures. So you have like wellness assessments that take other measures and put them all together into a composite. Okay? Those are just different measure types that we can represent. So then measure scoring types. Proportion, ratio, and continuous variable are the most common at this point. So proportion, it's just how many patients received some treatment versus a total. So it's just a fraction. You have a numerator and a denominator. Ratio is the same as proportion, except the numerator and the denominator might not be from the same set. It may actually be disjoint. We'll look at that a little bit more in the next slide. But and then a continuous variable is something that actually evaluates some function. So median time to arrival and departure, or median time from admission to discharge for an ER visit, something that measures and can fluctuate over time. So those are the three most common types that we've got right now. Each of those then have population criteria types. So you have your initial population, your denominator, and your numerator. And within those, you have some exclusions and exceptions. We fit all of those measure types and scoring methods into the same set of population criteria. And that's to give kind of just a consistent view of the structure a measure, so that we have a way to talk about and compare measure definitions between each other. So this is a proportion measure population diagram. You can see you start with an initial population, which usually is based on some demographic. And then you narrow that population to a denominator that has some characteristic feature that you're interested in. And then you narrow that further to the numerator that has the characteristic that you're interested in either improving or reducing whatever your measure is about. But by fitting all measures into this kind of category, then we provide a way for implementation engines to actually evaluate these things in a simple, straightforward manner. Denominator exclusions just keep people out of the population. A denominator exception is a little bit different. A denominator exception means you only come out of the denominator if you're not in the numerator. It's just a way to start to try to adjust for risk factors that might not be visible in the measure in other ways. And then numerator exclusions removed. So there's one more kind of axis on the populations, the patient-based versus episode of care. So a patient-based measure says the individual measures of this population they're all patients. So we're looking at populations of patients, and the criteria are expressed in terms of patients. Whereas an episode of care measure, the individual cases within a population are encounters or procedures, some other actual facet. And what that does in terms of how you define the measure is change how you express the criteria. For a patient-based measure, you're going to say true or false. The patient has this encounter. But for an episode of care-based measure, maybe you're actually counting encounters that have occurred. And so you want to return the criteria is a list of encounters. And then in, say, the numerator, the encounters would be encounters that had a particular procedure that you're interested in. Does that make sense? Any questions so far on measure definition? This is all just kind of general, and then what we go from here is how we actually represent this in FHIR. So the measure resource in FHIR is capable of capturing all that information that we just talked about. So it starts with metadata. You have identifiers, you have narrative description, governance type information, supporting evidence, and relationships to other artifacts. I can say that this measure is related to this guideline. I can say that this measure is a successor of another measure if it's replacing it. I can point to programs that the measure is involved in, those types of categorizations. And then the actual structure of the measure, where I say, here's the initial population, here's the numerator, here's the denominator, and what those population criteria are. And then the logic is where I actually define the conditions that go in to make up the actual criteria. So we'll start with, this is kind of a simplified view of one of the HEDIS measures. We've got, this is the declaration section of the library in CQL that defines this. So start with just naming the library. And specify that you're using a particular version of FHIR. So I'd say using FHIR version 3. You might say I'm using QDM. You might say I'm using CPA, whatever your actual model is. In this case, we're using FHIR STU3. And it's 3.0.0 because I built the model info off the first cut of the FHIR release, and yeah, I've updated it to 3.0.1. Although I don't think there are any structural changes, so I don't think it matters. But anyway, next you've got terminology. So within CQL, you can talk about terminology, and measures use a lot of terminology. So they use value sets to define the relationships within the criteria. And so you can describe an identifier for a value set pointed to its actual terminology, so that should resolve. These are all in the VSAC, so they'll actually resolve using that void in the VSAC, which is if you're not familiar, the VSAC is a CDC operated, or not CDC, NLM, National Library of Medicine. They operate a terminology server that supports a lot of the meaningful use value set program measures, and the CDC also puts a lot of their public health value sets in the VSAC as well. So it's Value Set Authority Center, and you can get a license there if you want, and they have an online browser and all of that good stuff. So if you look up those value sets, you'll see that they just contain different codes from different terminologies that indicate these ideas. So this concept of bilateral mastectomy or mammography, they collect codes from different terminologies that mean these different things, and then you can impose those as filters on data that comes from the EHRs to try to detect whether that condition holds for a patient's information. Then you need to find a parameter, the measurement period, that's typically provided to the report to say how long you're interested in. It's generally a measurement year, but we can provide that as a parameter. And then the context is patient, and that says all of your expressions are going to be interpreted in terms of a single patient versus a context of population that says all of your expressions will be interpreted across the entire available patients within your system. Does that make sense? Any questions on the library declarations there? This kind of just sets up for describing the logic in the next step. All right, so then we have an initial population. So this is a HEDIS measure for breast cancer screening. So the initial population in terms of demographic is that the patient is female, the patient is age 50 to 74 at the end of the measurement period. And we just use some straightforward CQL to express that. So that shouldn't be a surprise. Pretty straightforward. So then we go to the denominator and the numerator. So the denominator is the same as the initial population. The numerator is the initial population, and they have had a mammogram in the last 36 months. So that had a mammogram in the last 36 months is there's a procedure in the mammography value set where the status is completed, and it was performed during the interval from 2 years before the measurement period through the end of the measurement period. So we've got that 3-year window, and we're looking to make sure that the patient had a mammography in that window. Straightforward. So let's dig a little bit into what's actually going on there. So the retrieve and data requirements. So see the little square brackets in CQL. That means find procedures for this patient that have a code that's in that mammography value set. So there's kind of an implicit reference to the code here. That's the first thing that's going on there. Is that for each type, there's some default filter that you would use to identify what kind of thing it is within a value set. For procedure, that's code. For observation, that's code. It's typically like encounter, that would be the class encounter. And it's typically the most selective index on that particular type of data. So you don't have to use that default. You can say, I actually want to see procedures by severity or observations by value. You can use a different filter. There's syntax for that in CQL. But by default, if you leave it out, it's going to use the primary filter there. So what's happening there then is that I can express that this expression now has a data requirement of procedure filtered to the code with a value set string of mammography value set. So this tells me from the data requirement perspective, I can just look at this structural information and determine what data I need to be able to provide to this measure in order to get a successful evaluation. So this is useful for implementations to be able to figure out what data they need to provide without having to run the full measure to figure that part out. This same data requirements functionality is used in the decision support space when we use this same logic on the decision support side to say, this is the data you'd actually have to send me in order to get an evaluation for this piece of logic. Does that make sense? All right. So we'll take that a step further and we can go dynamic data requirements. Note that the data requirement as it was specified before would have given me all the procedures for the patient over the entire life of the patient, over their entire history. But what I really need when I'm evaluating this measure is procedures in the last 3 years, because I don't care about anything that happened before that. It doesn't impact that particular piece of logic. So I need procedures in this particular value set within a particular date range. That date range depends on when I run the measure. And so I can't know ahead of time what that date range is. I have to determine it based on the actual values I'm going to use when I run the measure. And so there's this data requirements operation that actually lets me do that. So I say, what are the data requirements for this measure, given that I'm going to run it for a period of 2016. So in the 2016 reporting year, what data do I actually need? And what it comes back with is, well, you need procedures in the mammography value set, but in that range from 2 years before the measurement period through the end of the measurement period. And it does that by, it's a static analysis with the addition of the parameter values. And so it detects that expression is referencing this parameter, and it can now provide the value of that parameter. So it can do it without actually evaluating the CQL, but it still gives you the ability to filter down even further than you would otherwise be able to. So now I know that I only have to send 3 years worth of procedures instead of all of the procedures. Does that make sense? Any questions on that? All right. So there's another piece here that I want to dig into a little bit, is using profiles to communicate those requirements. So we noticed that we're saying proc.performed. So this is the, in CQL, when you when you have a choice of values, like procedure, performed, that can be either a date time or a period. So in CQL, if I treat it like an interval, then it will behave like an interval if it's a choice. CQL knows that the performed is either a date time or a period, and it knows that in this case, I'm invoking a period operation on that, and so it will actually implicitly cast that to a period, so I can work with it that way. But what if the data comes back as a date time? In that case, I won't get an answer. And so, given that the resource allows me to express performed as both a date time and a period, I would typically have to change my logic there to say, if performed is a date time, deal with it this way. but if performed as a period, deal with it that way. So,
just to add something, also when it's a period and the beginning of the period is within the measurement period and the end of the period if the procedure is outside of this period, you have to specify that as well in the logic?
you do have to specify that in the logic. So we use a during there, which means that the entire period has to be inside.
That's what it means.
But you can say things like overlaps or starts before. There's a whole range of timing expressions that you can use to relate the periods together. In this case, we're taking the during and making sure that it's entirely contained within the measurement period, or at least within that 3-year interval from the start to 2 years. So we don't want to have to complicate the logic, at least as much as possible, by having to check if it's a date time, deal with it one way, if it's a period, deal with it another. And so what we've done is defined a profile to say, if you want to run this logic, then you need to specify your performed as a period instead of allowing the more flexible procedure resource down in the base. So we constrain what we want the procedures to look like in order to evaluate this. Now we've done this, and we're currently in the process of testing this with the consumers. Obviously, variability is kind of the enemy of interoperability, and so we want to impose something like that. But if it then turns out that becomes too much of a burden on the implementers, then we'll back off. But what we've done is kind of drawn a line in the sand and said, we're going to define these profiles. How hard is it then for the implementers to provide the data conforming to these profiles? Because with the profiles defined this way, we can get more straightforward expression of the logic. And you can imagine how that works for lots of different things, right? Blood pressure, we don't know whether we want it to be different observations or components within a single observation. Depends who you talk to, how that gets modeled. And so what we're going to do is define a profile and then say how we want it to work in our scenario, and at least then we can communicate what those requirements are and the expectations.
So you mentioned profiles. Is there any way to specify profiles in SQL? So
yes.
Computer can understand this algorithm should be run against a particular profile-based data.
Yes. What you do is your model, the model info is a description of the structures that are available. And so within your model info, you can say what the procedure profile that you're using is. So in this, we're saying procedure here, but we would actually be referencing the HEDIS procedure profile. You can define as many top-level types in your model info as you want and have different ones that point to different profiles. So I could say procedure is the base. I could say HEDIS procedure is the HEDIS profile. I could have a CMS profile that pointed at a different one. But the model info actually says what profile you use. So there's a way to do it, but you can hide it within CQL, or you can expose it by name as well. Depends on where you want the author to be exposed to your model. If that makes sense.
Oh yeah, as long as there is way that algorithms understand, right?
Yeah.
Specify that information. So
Yes. Okay, any other questions on profiles? All right. All right, so then how do we take this data and run it and actually get a measure report? So that's what the measure report resource is for. So measure defines the actual measure and the populations and all the information about that. And then measure report is what I get back if I actually evaluate one of these. So it's kind of like questionnaire versus questionnaire response, or procedure request versus procedure. This is, measure report is the actual result of evaluating the measure. It follows the same structure, so measure structure. In the measure, you can have any number of population groups. Each population group has any number of populations. Typically, they're the ones that we enumerated, but you can define your own if you really want to. And then within that group, there are also stratifiers. So I can take those populations and stratify them by different criteria, like age or gender, whatever. And then supplemental data is, think of this as projection. In addition to the measure score, for each member of the population, I want to capture things like gender, whether they're deceased, additional information that I want to report as part of the measure, but that isn't part of the measure score. You can also do things like risk factors here if you want to, if you have a measure that is particularly sensitive to risk adjustment, you can specify what your risk factors are and have those come back as well as part of that. And those risk factors can themselves be calculations so that you can build a risk model as complicated as you want. So then the measure report follows that same structure. This is an individual report, so your population is 1 or 0, like you're either in or out of that population. If you run this for a summary level, then you don't get the resources. The resources are per individual. So these are the resources that were involved in performing this calculation. So if it's procedures, then you get the procedures that we looked at to determine whether this patient was in the population. At the summary level, you'll see actual numbers in there. So the initial population is 500, the denominator is 250, and the numerator is 125. And then there's one more way that you can run that with a patient list, which is actually an individual report for every member of the population. So it's summary, but then you get the actual patients involved in each of these. So you can get that level of detail if you really want. The summary is intended to provide just the aggregate response. The individual is per patient, and then if you really want all the data, you can do a patient list. All right, so can we do better? At the Digital Quality Summit 2 weeks ago in America, and we asked this question: can we do better? Can we take the access to additional information that something like FHIR enables, and can we improve these measures? Because right now, that measure in particular, the breast cancer screening, is based on billing data. It happens 90 days after the fact at least, sometimes even longer, sometimes 9 months. So that's a very retrospective view of care. Can we get more prospective by getting access to this additional information, clinical information that's available now through these FHIR APIs? Which would be great. We can improve quality measurement in this way. So it turns out with breast cancer screening, one of the guidelines that's well established but is not incorporated into that HEDIS actual measure is looking for what's called a BRCA mutation. I have no idea what that means, other than that it's a particular genetic mutation that increases a woman's risk of breast cancer earlier in life. And so the standard screening says from 50 to 75. With the BRCA mutation gene, that guideline changes to say it should start at 40 rather than 50. And so can we improve the screening rates based on this, the existence of this mutation? So So we define some value sets to look for this mutation. Either they've had the procedure and there's a positive finding, or there's an observation of the BRCA1 or BRCA2 mutation, or there's a history of the BRCA mutation in a child, a parent, or sibling, indicating that they may also have it even if they haven't had the test. They may still have the mutation because there's genetic history of it in their relationships. Now, whether or not that data is going to come back is another question. You can think of it as pretty unlikely that so we talked about different ways of expressing that. Maybe you would actually go to that other sibling's record and pull that back. But whether you can traverse relationships like that within an API is another story. So we kept it simple as family member history. If it happens to be the case that this patient has recorded the fact that their parent had this mutation, then we'll hit that. So that's the refined BCS measure. We just added that condition to say either they're age 52 to 74 at end, or they're 42 to 74 at end and has BRCA mutation results. So now if they're younger and have this mutation, then they also appear in the initial population. Okay. So then what we did, the next step there was to derive decision support. So we have this, a quality measure. Can we improve the metrics on that quality measure by intervening when there's a potential for missed opportunity? So we know by looking at the decision support time whether they've had these screenings. We know the criteria. We can take that same logic and pull it out into a common library there and reference that from the same place, or reference that from the decision support. So now we can say needs screening is that we've got the a little bit different criteria in terms of the age to support that we're looking prospectively instead of retrospectively. But the general logic is the same, and we're able to reference that has BRCA mutation indicators to say look even earlier. And then we can use the same exclusion criteria, and we can use the same screening criteria. So we're able to take that decision support, or we're able to take the logic from the quality measure and actually use it in a decision support artifact. Okay, so these are some track resources. They're the same slides as yesterday's. Those are, the first one is a CDC opioid prescribing support implementation guide. The second one is the NCQA's HEDIS FHIR implementation guide. This is where the breast cancer screening measure that we just looked at is. And then these are publicly available test servers that can actually run these. So if you want to run that screening measure, you can use that endpoint to do it. And then there's some walkthroughs that actually walk you through doing that with those endpoints. So these are kind of the exercises for the track, if you are so inclined. Questions? Sorry, do you need to go back?
Yeah.
Go ahead.
Sorry. Okay. So are there any tooling can support transfer this kind of SQL to whatever query language that can run this?
Yeah, so we have a Java-based engine that can actually run it. And that's the CQF ruler that endpoint is running. But we also have transformation tooling in .NET that can transform the CQL to SQL. It's pretty rough, but it is there, the start. Yeah. So.
publicly available?
Yeah, those are all on GitHub.
Okay.
And that, if you go to that, some of the walkthroughs, those have that. So there's a GitHub CQ framework organization, and that's where